Welcome, everyone, to the Cultivating Compassion Education series, sponsored by Compassionate Care ALS. We're delighted to have with us today Dr. David Seres, who will be speaking on what happens if I can no longer eat, medical nutrition for those living with ALS. David is a good friend of Ron and mine. We've known him a long time. He's been a medical nutrition specialist for 35 years and recently retired as professor of medicine at Columbia University Medical Center in New York. He's an internationally recognized expert at providing nutrition support for patients with ALS and many other conditions when eating is no longer possible, as well as being a medical ethicist. So thank you, David, for being here with us today. Great to have you. We also have our founder and CEO, Ron Hoffman, with us to say a few words about David before we begin. Hi, Ron.
Hey, James, thank you. Thanks, everyone, for being here. David, thanks for showing up. Yeah, David, James and I go way, way back. So just a few of my own thoughts here. In my 28 years experience in the world of ALS, the vast majority of the folks say yes to getting a G tube, feeding tube, whatever you wish to call it. For those of you that know me, you've heard me say I'm never attached to any choice or decision anyone ever makes. If I am attached to anything, it's you have all the information to make conscious choices, conscious decisions. What does it mean to say yes to a feeding tube? What does it mean to say no? And gathering all that information, right? It's a procedure. And as we know, procedure have consequences. The vast majority of the time, saying yes to a feeding tube is a very simple procedure, the vast majority of the time. And yet things can happen. And then, of course, there's the choices. What type of system do I get? What type of formula do I get? And, over the years, I've had the great fortune to know David. And unfortunately, maybe there were circumstances where one of our families was having an issue. And I would pick up the phone and call David, and David graciously would reach out to the family, help them navigate their complex circumstance, and find a positive result. So anyway, thank you all for showing up. David, thank you for being here, and I'm going to turn it over to you.
Thanks. Thanks, Ron. And thank you all for being here and letting me speak to you. I want to say that this is an issue that affects really pretty much a majority of people who are dealing with ALS. And I'm going to give sort of a high level overview and leave a lot of time for questions. There's things that we don't know, and this might be a difficult talk. There are a number of elephant in the room situations here that people are not aware of, and I'm hoping to kind of bring you into the know on this. I will pull no punches. I'm going to be describing some complications. But as Ron said, these are really rather unusual, and I'll also mention how to prevent the worst of them. Please, please, please note that I am not giving out any medical advice. This is for education only, and that you should discuss any medical decisions with your provider. I am available if things get hairy, though, and just to provide, as I said, educational advice. So there are a bunch of different things that we're going to talk about. I'll go through each of these one by one. Actually, these two are going to come together at the same time. And then we'll talk a little bit about how to go about choosing and how to influence your doctor to act ethically. And then we'll leave it open for questions. In the beginning of any talk like this, you hopefully will hear from the provider or the presenter whether or not they have any conflicts of interest. One of the things that I found out in life is that this particular conflict of interest of mine being that I really love an audience and that I am an expert, both of those really put me into conflict. And I will hopefully not say anything just to be cool, which a lot of people don't realize that they're doing. They'll offer opinions without telling you that they're opinions, and I hope not to do that. grind my axe. So one of the things that I want you to be aware of is sort of why it is that science is so confusing, and why dietary recommendations change, and why it is now. I was just talking to Ron and James. There are actually commercial that you can buy coffee with beef tallow already added to it, and I find that just horrendous. But the reason that these things can become so popular is in part because of the nature of the way science works. There are two different kinds of science. One is that when you have good randomized controlled trial where you take a population that's similar and you randomly assign them to get one thing or another, and then you can compare the two. However, most nutrition research and a great deal of medical research is what we call observational. In an observational study, you look back over time, or you can look forward over a period of time, and you look to see if two things are correlated. The problem with observational research is this. I have a little parable, and it has to do with the seatbelt sign on an airplane. I'm a smart guy. I'm a professor at Columbia, so I must be a smart guy, right? Well, I have embarrassed myself by going up to the pilots and telling them that I have done an experiment over the course of my lifetime. I've been on hundreds of airplanes, different routes, different airlines, different crews. And there is a very high correlation between the seatbelt sign going on and the ride getting rough. Therefore, I implore you, please do not turn on the seatbelt sign because you're making the ride rough. Now, that's silly, of course, because we all know that they're getting radio and radar and all kinds of information about the way the air is into which they're moving. And that's why they can predict whether or not the seatbelt sign should go on and that everybody should be seated because the ride is getting rough. They have no causal relationship. But you'll hear time and again, especially on the evening news, that such and so study just showed that coffee can cause hair in your nose. And you say to yourself, well, wait a minute, the study 2 weeks ago said that coffee prevents hair in your nose. And what's going on? And what is going on is that these are observations and not good randomized trials. And you should pretty much turn your ears off anytime one of these comes on because it will mislead you. In fact, somebody did a study of this some years ago. It was a 125-page report commissioned by the NIH, done by the Tufts by some friends of mine, and they looked at the observational studies and the conclusions drawn from those observational studies. And they compared them to the actual outcomes of the randomized controlled trials, and there was no concordance. In other words, you could flip a coin and guess whether or not there was actually a causal relationship based on the observation. So that's why it's so confusing out there, and that's hopefully I've given you a tool to interpret why it is that science changes. Well, science changes a lot. Look at this. This was the very first. Anybody here know somebody with asthma or has asthma? You know that we use these inhalers. Well, the very first inhalation therapy were actually tobacco cigarettes laced with an ergot, which is something that will cause the airways to open up. But the tobacco is probably going to make it worse. So this wasn't a great idea. And then fast forward to the 60s, doctors used to fight over getting hired to do. These are real doctors who were hired to do these commercials and tell you that they know that in the T zone, which is where you taste, if you don't look at the bottom left here, that's where Camel has its advantages. And so, and I will also tell you that there has never been a human randomized controlled trial that actually proves that cigarettes cause cancer, but there's a large animal, a body of animal research. So just sometimes we do know things, but most of the time we don't unless there's a good randomized controlled trial. So let's start with what are the things that happen with ALS that will make things hard for you to eat by mouth. And, the medical term that we use is dysphagia, dys meaning bad, and phagia, it refers to swallowing. And it really just means it's hard to swallow or you're not able to swallow correctly. And it's really caused by the same process that is causing everything else in ALS, which is muscle weakness due to a loss of neurologic stimulus. It happens pretty commonly. About 2/3 of people living with ALS have documentable changes in their swallowing. Now, I want to point out here that abnormal finding on a test does not equal by 100% the need for anything in general. In ALS, we know that there's going to be a progression, and at some point, the swallowing will be severe enough to really require attention. And so, doing this test, while it may identify that you have a risk, it may not mean that you need a feeding tube today, but it will give you a sense of sort of how far along things are and whether or not you need to start thinking about it. And really, it's not a bad idea to start thinking about it. It's not a bad idea for everybody to start thinking about it, whether they have ALS or not, because some things happen sometimes where people are not able to make decisions for themselves, and they should have in advance a directive and people who are willing to make decisions for them. I will say that in spinal onset ALS, it's less common and it's much more frequent, and it happens earlier with bulbar ALS. And your provider should be able to tell you what you have and where you stand as far as the risk for swallowing problems and where you stand currently. So what are the consequences? Well, simply enough, you just aren't able to eat enough, and so you'll starve. And I just want to put a pin in this for just a half a second here and tell you I'm going to talk about malnutrition and starvation a little bit, but I'm going to warn you that there are a whole lot of reasons that people develop wasting that have nothing to do with nourishment. And we'll come back to that. It's a little bit confusing even for my colleagues. So keep paying attention. We'll get into it. Not being able to eat can have a negative impact on your quality of life. So much of what we do socially is related to food. And what if you're not feeling well because you're weak from starvation? Well, that's going to impact on your quality of life as well. Having disordered swallowing does put you into a class of risk that's higher for developing pneumonia than people who don't have problems swallowing. That risk is just an association, and there's always a question of, how bad does it have to be and so forth. It's really kind of up in the air. And so if you feel like you're getting wishy-washy answers on this, it's because we're really not sure. I will say that the main indication, while possibly decreasing the risk of pneumonia is one reason to have a feeding tube, the main reason for it is to prevent starvation. Because lots of people, let me say it a different way, everyone has some degree of aspiration. Some of the studies show that normal people without any kind of disease or swallowing problem, have aspiration events every night at a rate of about 50%. So, and the risk of pneumonia in that population is not 50%. So there's a great deal of focus on aspiration, that it may be overblowing the risk of pneumonia. Suffice it to say, pneumonia is something I really don't want you to have. And not putting food in your mouth will probably decrease that risk, but you still have to deal with your own saliva. So it's not going to make it go away, but it should help decrease it. So the main reasons for doing tube feeding would be to maintain your vigor and health that is related to nourishment. So now I'll talk about that confusing thing. What it is that makes people lose weight. And there are three different inputs that could cause you to lose weight. One is the nutritional, and that's pretty straightforward. You're not eating enough. It's also possible if you have a bowel disease, for instance, that you have excessive losses. We call that malabsorption and so forth. But it's not necessarily germane to this conversation, but I mentioned it just for thoroughness. And then there are neurologic phenomena. And when you have a neurologic disorder such as ALS, where the stimulation of muscles by the nerves decreases, then the muscle bulk will decrease. And if you think about this, think about it, about how if you exercise, especially if you lift weights, your muscle bulk increases. And it's the same thing in the reverse, that if you decrease the nerve stimulation and you don't exercise the muscle, it will decrease in size. So here's where it really gets a little confusing, and that is that there is a phenomenon in disease, and not so much in ALS by itself, but if you had pneumonia along with your ALS, and your body becomes inflamed, medical inflammation causes muscle loss and a whole bunch of other things as well. So by definition, this is referred to in a lot of different ways. And part of what I'm doing now that I'm retired is writing and speaking on the issue that all four of these things are essentially identical, but there are different organizations devoted to each, and they're all trying to prove that they know the right way to speak about this. And I think that it's causing a great deal of confusion out there. It has for decades. And it's sad to me that I think that it actually has slowed down the research into it. But suffice it to say that none of this is due to nourishment or is responsive to nourishment when it's due to an inflammation from disease. And it can cause muscle wasting just the way a neurologic loss or starvation can cause muscle wasting. But there are other things that it can cause that are not not related. And I mention these because somebody may tell you you have malnutrition. And if they're doing it based on an inflammatory disease and the outcomes of that, you may be perfectly well nourished. And the terminology is confusing, and I apologize. And I've been yelling about it for about 20 years. I'm finally getting some traction, and maybe someday we'll actually talk about this in a way that we all agree to. But for the time being, if you are told you have disease-related malnutrition or malnutrition based on the fact that you have swelling or low blood proteins or any number of other things, and you're being fed adequately and there's nothing wrong with your intestine, then it's definitely not your fault. It's the underlying disease. All right. So what are the options and what are some of the risks? So the first thing we always try to start with is oral supplements. Now, oral supplements in problem when somebody has a problem with appetite they're usually pretty useful. And we've been able to show in good studies that we're able to increase intake. If your problem is your ability to swallow, then they may be helpful because they're kind of thicker and they can even be thickened further. And so people with early swallowing dysfunction often find them to be useful as well. There are many that are available commercially. There are so many brands with so many claims and so many thises and that's. The bottom line is that there probably doesn't matter. And you should find one that, if you're going to use it, an oral supplement, Ensure is one of the more common ones, or Instant Breakfast, or any of those. You find one that's palatable and that you can afford. Boost, they all have about the same amount of protein and calories and so forth. And each product will have a range of calories and protein in it. Do not make yourself crazy, please, because it probably doesn't matter. And really, I think that the main thing you should focus on if you're drinking a supplement like this is the besides the palatability and cost, is the calories total, because you'll get the protein with it, unless it's a low protein product, which I haven't seen for a long time. We used to market those for patients with kidney failure and found out that we're probably harming them. So you don't worry about the protein. One of the reasons I say this is because in order to make a product that is higher in protein, or any alteration, requires a lot of work, and it really also, generally speaking, ends up with more processing and so forth. And really, to be honest with you, these foods are really could be considered ultra processed foods, although we call them medical foods because of their use and the context here. A lot of people like to make homemade shakes, and that's fine, but you got to worry about a few things if you're going to do it. First is the thickness of the liquid. If you have a problem with swallowing and you need food that is thicker, and this gets a little bit complicated at first when you're first making the product, but it even gets more complicated if you make something using things that can melt. So a nice thick smoothie with ice in it is going to get thin if you leave it sit around. So you have to just be careful with that. There are commercial products for thickening liquids. And the good news about all of those is that they're basically fibers. I'll take a little side note here about fiber. There are many different kinds, and some of them are gelatinous. And the gelatinous fibers, you've heard of Metamucil. Well, that comes from the psyllium husk. If you take a psyllium seed and you drop it in water, it develops sort of like this mucus on the outside of it, and that's fiber. It's a soluble fiber, and that's really good. It'll help your cholesterol, after all. But it's also it gelatinizes, and it will thicken any product. When you make something at home, you got to worry about these things: contamination if you leave it sitting out, and that kind of thing. You also got to worry about nutritional balance. If you have access to a dietitian, they love to talk about how to make these products, because so many people who are receiving tube feeding outside of a hospital do this because it's convenient, it's much less expensive, especially if the insurance isn't covering the commercial product. It's sort of aesthetically more pleasing to take what you would normally eat and throw it in a blender, after all. And that's a good way to go about this. But if you're taking it as an oral supplement, you need to worry about the thickness, as I said. And if you're using it for tube feeding, you got to watch out for, in addition to all of this, whether or not it's too thick and will clog the feeding tube. But again, the dietitians love to help with these kinds of things. And the other thing that you can do with the blender is to take a commercial product like Ensure and add something to it that makes it taste better. Ensure and ice cream, or Ensure and some flavoring or some fruit. You can't break the Ensure. It's not like milk where you have to worry about it, kind of coagulating and things. Although it's possible to coagulate it if you add lemon juice right to it, it might clog up and turn into cottage cheese. But suffice it to say that the blender is a useful thing if you're going to try and do an oral supplement that's commercial. As I mentioned, talk to your dietitian, and then also the speech pathologist, and hopefully everyone has one, and who can advise them on the consistency of the food that they should be eating and so forth. And this team of the two should be able to really help you navigate the period of time before you're needing a feeding tube while you're swallowing isn't quite right. So let's talk about tube feeding. There are several ways to go about tube feeding, one of which is a little thin tube up the nose called a nasogastric tube, naso and gastric for nose and stomach. And this is something that I've been working on for quite some time, because one of the problems with it is that while the research is very clear that it's very much acceptable for long-term use, most of the facilities, the skilled facilities, nursing homes, will refuse to take them, at least in the New York City area. And I know that it's gotten a whole lot worse throughout the country based on anecdote. And this is, it drives me a little nuts, I have to say, because this is forcing people to have gastrostomies who need to go into nursing homes and don't want them. But again, as that's an ethical issue more than anything else, because if you look at the research, the outcomes from nasal tubes used long-term and the outcomes from gastrostomies used long-term, they're pretty much identical. And so there's really nothing that favors one over the other, just from a purely scientific perspective. And so we are denying people the choice of one or the other. And choice is one of those things that I'll talk about when I get into talking about ethics a little bit, that is really crucial here. And these are some of the concerns that they have. And again, as I say, they're either any of these things happens extremely rarely. I will say that cosmetics is one of those things that favors the gastrostomy, the feeding tube that goes through the stomach. And, you know, of course, if you've got a tube in your nose, you don't really want to go out in public with that. Then you'd probably rather have a tube that hides under your shirt, which a gastrostomy will do. But the rest of these things are really unfounded. And any of the differences are very, very small and inconsequential. This little device at the top here, can you see my pointer? Okay, this little device here with a clip on it is what's called a bridle or a nasal securement device. And this is placed, this little piece of tape, actually they use more like a little skinny soft tube now, is placed around the back of the nasal septum. It takes about 30 seconds. It's not, it's less, I can tell you that it's less uncomfortable because I've done it on myself. It's less uncomfortable than a COVID test to have this put in. And then once it's in, you don't feel it. And this greatly improves the security of the tube so that they don't fall out. And we're using that as a lever here in New York. We've got 7 nursing homes that will now once again take these feeding tubes. And that's particularly important in the short term. But I kind of want you to know that it is an okay solution for the long term. But there's a but, and I'm going to get to that but in a minute when I talk about timing. But I think it's important to know that at least that this should be available to you, but it may not be because of the culture that's developed around it. I can tell you actually the story that happened was in the early 90s, and everybody was running around with their hair on fire about a patient who had one of these tubes placed and it went into their lung and the patient died, and it was a horrible thing. And then once the dust settled, I realized that I had heard the story at 4 different hospitals about the same patient at that hospital, and was never, I actually tried to find the actual patient and it really could not. Now I'm certain that this has happened to somebody, but this is basically the nursing homes deciding not to do this based on urban legend. It's been a project of mine for a number of years, and as I said, we're getting some traction, and we've got 7 nursing homes that will take them. But be aware that you're probably not going to find that outside of New York. All right, so here is the gastrostomy. And what is a gastrostomy? A gastrostomy, this diagram down in the middle of the bottom, is sort of how they do it. They take a scope, put it in the stomach, and poke a hole between out of the stomach and in through the abdominal wall. It's usually not out the side like this. This is schematic. It's more like it usually on the front of the abdomen, as you can see up here. This on the top is what's called a low profile or Mickey gastrostomy. And it's nice because the tube comes off to the side, and it's got, you know, it's low profile and it doesn't stick out. The downside to these is that the tubes are rather small, thin, and that they probably may clog a little bit more. But really, it's an okay solution. The low profile cannot be placed initially during a first procedure, but once the tract has matured after about 6 weeks or so, it can be substituted for the gastrostomy, and usually that can be done at the bedside without any anesthesia, whereas this procedure does require anesthesia. This tube that shoots off to the side disconnects, so all you've got is this little button there when you're not using the tube. A regular gastrostomy, like the one on the bottom right here, this is a mannequin. This gastrostomy is held in place with a ring on the outside and either a ring or a balloon like the one on the left on the inside. And then there's a tube that hangs out, which again, as I said, you can hide under your shirt, but nonetheless, the tube disconnects from this low profile tube. So that makes it a little bit nicer. Okay. So we talked about the concerns with the nasal tube. The concerns with the gastrostomy are pretty close to the same. And so, and based on fairly large randomized trials using the nasal tube or the gastrostomy for longer term use, they sort of come out equal. And it may boil down to what kind of support system you have and whether or not they can support one or the other properly as to how you decide. There's something that I want you to be aware of, and that is the distance between this and this is extremely important, because way back when I first started, we used to use Foley catheters, which are the ones that go in the bladder, and all there was a balloon on the inside. And what would happen is the stomach would start to peristalsis, would drag this tube inside, and this balloon would end up blocking the exit of the stomach, and it was a real pain. And so they invented this ring for the outside to keep it from sliding in. That is its sole purpose. Sometimes these tubes leak. As a matter of fact, most of the time, there's a little bit of mucus that's made by the lining of the tract, and it looks like a runny nose. Unfortunately, it looks a little bit like the tube feeding. And so people freak out and they say, oh my God, it's leaking. What should we do? Well, the bottom line is that a little soap and water is all you need, and you shouldn't tighten these. And the rule of thumb is that they should never be tight, because that crushes the tissue of the abdominal wall. It should slide in and out. Anybody who has one of these tubes or is going to get one, please remember this, that about once a week you should check, and lying flat on your back, the tube should be able to slide in and out about an inch. And that way it doesn't crush the abdominal wall when you're upright, and it won't cause the problem I'm about to show you. When there's leakage and someone says, tighten the tube, they're assuming that this ring and this balloon are creating the seal that prevents leakage, and they do not. What prevents the leakage is the abdominal wall snugly around that tube. But in order to be snug around that tube, there needs to be no pressure on it, either from both ends, the way these things might, or laterally. So these tubes need to be straight up and down. And one of the reasons that these rings are as large as they are is to keep the tube facing straight up and down so that it doesn't stretch the hole. And the last thing you want is for that hole to stretch. Now I'm going to show you a picture of a CAT scan of what happens when somebody keeps tightening and tightening and tightening these tubes. And that can happen in two ways. One is that somebody actually tightens it, and the other is that if you gain weight. Because if you gain weight, your abdominal wall will thicken. And it's just the same as if you tightened it. And that's what happened in this case. And you can see this balloon is now embedded in the abdominal wall. It's eroded through the stomach wall and out into the abdominal wall. This is what we call a buried bumper. And this is something that you very much want to avoid. And that's why I'm teaching you the rule of thumb, because so many of you will end up with gastrostomies, which are a really good thing, except if they're not managed properly. And this is one of the more serious complications that I hope to help you prevent. The last way to increase calories is if your intestine is not accessible or doesn't work, we can feed you intravenously. And it's called parenteral nutrition, para meaning around, and enteric, enteric meaning the intestine. And these are a bunch of abbreviations that you don't really need to care about, but you'll hear them all. And just so you know that it's effective, it's been around for about 70 years, and there have been people who've been kept alive on it for 40 years, people who've had horrible accidents and have lost most of their intestine and things like that, or have diseases that destroy the intestine, like Crohn's disease and so forth. And this was the main focus of my practice. There are risks. They're not that great. Risks of blood clot from the catheter, bloodstream infection. The bloodstream infection risk is approximately 1 episode every 1,000 patient days. So you'd have to be on it for a year, for 3 years to really to be at high risk for developing a bloodstream infection. And there are people who never do. And then if you're not being being managed by somebody who knows what they're doing, that can cause an electrolyte imbalance. It does require greater provider expertise. It's more expensive, and it's often refused by facilities, and also hospice because of the cost and complexity of it. But I wanted you to be aware that it's available if all else fails and you are still wanting to be nourished. These are the catheters that are used for infusing things over a longer period of time, like you would need to with parenteral nutrition, intravenous nutrition. The first one is a portacath, and what this is it's a nipple that's put in under the skin, and then the catheter goes up into one of the big veins. And what you do is there's a special needle that you poke through the skin into the receptacle here, and it can be used intermittently. And it's very commonly used for people who are getting chemotherapy or immunoglobulins. Some of you may have one for something like that. It's best used for intermittent infusion, although there are some centers that use it for home parenteral nutrition. I will say that none of these things that I am mentioning require that you stay in a hospital for the rest of your life. There are some 50,000 people who are getting this parenteral nutrition at home in the US. The other thing is a tunneled catheter. A tunneled catheter goes in the skin here, it goes up under the skin into the vein in your neck, and then drops down into the bigger veins. And these are very good for using for long term. One of the things that we're now using more commonly than anything is what's called a PICC line. PICC stands for peripherally inserted central catheter. Central catheters, which are all these things end up with the opening to the tube right just before the heart, so that you've got the greatest blood flow going through, probably 15 liters a minute. And so you can put really concentrated things in there without burning the veins. Whereas if you tried to give them in a regular IV, it would burn the vein and cause all kinds of problems, and you wouldn't be able to infuse it. Anyway, the PICC line is inserted just inside the elbow, as depicted here. This is the crease of the elbow, and it's up just a little ways into the big vein that runs up on the inside of the arm, and then it's secured. These are really easy to place. Just about every hospital has a team of nurses who go around doing this with ultrasound and a little local anesthesia, whereas the tunneled catheter and the portacath require either to be in an interventional radiology suite or an operating room. These are technically a lot easier to place and replace and take out and put back in, et cetera, et cetera. So these are becoming much, much more common. They run the downside of the PICC line is that you can see that it's in the bend of the elbow. You see that the tube ends here. Well, how are you going to grab it with your hand? How are you going to have two hands to grab it? And so what you do, you put an extension tube on it. But it means that you're a little bit more dependent on someone else to help with care. But I will say that anybody who's got one of these in and has anything going into it will get a nurse visit from the infusion company at least once a week, which is as often as you need to replace the tubing and so forth. So it's really not that bad of a downside. Whereas you can see with this tube, with this catheter, you can grab it with both hands with a great deal of ease. But anyway, these are more logistic concerns than anything else. So how do you choose? And by how do you choose? I think it's important to point out how medical ethics works. These are the four main principles on which medical ethics is based. And let me go through them very quickly. Autonomy is the ability to make decisions for yourself. Beneficence is that you are compelled as a practitioner to do good. Non-maleficence means that you are compelled as a practitioner to avoid doing anything bad. And justice is the concept that everything should be accessible to everyone in an equal way. And these get more complicated, but for the sake of this argument, we're going to talk mostly about autonomy. And I really want to make sure that you hold your provider to these. The problem that, I mean, the main concept that you've probably heard that relates to autonomy is something that we call informed consent, meaning that you understand the risks and the benefits and can make an informed decision based on those. So here's the elephant in the room. There are no randomized trials. So I don't know. I looked actually again to make sure, but there are no randomized trials in patients with ALS to know when or whether to put in and start feeding with a tube. And I'm sorry, I really am, because your provider can only then provide opinion and advice based on opinion as to whether or not. I have an opinion and I'm going to share it with you, but let me go through the data. Remember, I said that observational data is really often misleading. Well, here's a really important one. Guess if you have ALS and you get a gastrostomy, that is associated with a shorter survival. And you'd say, wait a minute, why am I doing that? I want to live longer because I don't want to starve. How is it that getting the gastrostomy shortens my survival? Well, I can't say that it does. In fact, I doubt that it does. What I think is that sicker people end up needing gastrostomies, and people who are sicker tend to die sooner than people who don't. And people who develop swallowing problems with ALS are probably a little further along than people who don't. And so, of course, the people who don't are going to live longer. So this is the kind of research that I want you to ignore, that I want you to just sort of say, okay, well, that's interesting. Now do the right study and tell me what it shows. And that's what one of the things that you can do is to try and lobby for better research. All right, so let us talk about the timing. Here's my only concern. The gastrostomy requires anesthesia, may require a ventilator. And especially in somebody with ALS, with decreased ventilatory function, they may require that you be on a ventilator in order to have the procedure. Oftentimes, a ventilator is used in just routine care. However, if you have decreased respiratory strength, and that's one of the things that ALS does, as you know, you may be unable to come off the ventilator after the procedure. So if you're going to, and remember I said early in the talk, I think it's never a bad time to talk about this. I think now is a good time to talk about this, because if you're going to choose to have a gastrostomy, in my humble opinion, well, maybe not so humble, do it sooner rather than later. But that's an opinion. There are no randomized trials. Now, the advantage of doing it early, there's several, in my opinion. Besides keeping you off the ventilator, it also makes it so that you don't have to sort of learn how to use it and be comfortable with it when things are getting problematic. Also, if you're better nourished when you have it placed, there'll be lower risk of complications from breakdown at the site and so forth. You'll heal better and so forth. But that is sort of a more theoretical concern than otherwise. So I think I think most people would advise not waiting until you really have to have it, but rather if you start to have swallowing problems and while your pulmonary status is still good, is the time to do this. And I do have a crystal ball. Actually, I do. It's on my desk, but it is useless in telling me how to tell people when to do things. And I apologize. I really do, because there really isn't good guidelines that say if this, then that. So I'll provide you with my expert opinion. Now, that ends the formal portion of my talk. Let me just say informally that I really, really worry about all of you a whole lot less than I worry about a lot of people with dealing with chronic illness, because at least you guys have CCALS and you have reliable sources. There are so many unreliable sources out there who latch on to things. As I mentioned, you can actually buy now coffee that is laced with beef tallow, which is really bad for you, as far as I know. All of the research would suggest it. I don't know what it is that they think that they're going to do to help people by recommending it. I do know that there is the theory behind recommending an increase in saturated fat intake is that that saturated fat helps increase the uptake of certain vitamins. But unless you have a vitamin deficiency or a problem with your intestinal uptake, eating more of the food that has the vitamins in it is the better choice. And all of the research supports that, rather than trying to eat more saturated fat in order to improve your vitamin intake. So stick with if you read any of the health newsletters and things like that, stick with the ones that come out of the universities and the medical schools. But I have to say, even those are sometimes tainted with opinion. I used to be on the medical advisory board for Consumer Reports, which is, everybody's favorite scientific journal, and a lot of what they've been saying of late is based on this observational stuff, and it really doesn't have the strength that it should have in order to become a recommendation. And I'll leave you with one last thought from Albert Einstein. I'm going to take a sip of water, and then I'll answer questions.
Dr. Seres, first question comes from Lynn. She's asking about how does one assess bioavailability?
Yeah, you know what? I need somebody to prove to me that bioavailability matters to health. And by that I mean that there are a lot of observations, as I've been saying, as to whether or not this one thing changes bioavailability or another. For instance, it's well known that for minerals like iron, if you take it with an acidic fluid like orange juice, it absorbs better. But the question is, so what? Does it really matter? Does it really improve outcomes? And I don't know. I mean, most of the studies of dietary supplements, vitamins and so forth, have failed to show really anything of benefit.
The next question, another one from Lynn, is nasal feeding tube is incompatible with NIV. I'm not sure what that means, but you probably are.
Yeah, well, I'm not sure, but I have a feeling I know, and that's positive pressure ventilation. I see that Lynn is wearing a device that is probably providing positive pressure for breathing. And Lynn, you ask a really important question with this, and there are varying opinions on this, but most people would say that any kind of positive pressure mask, like CPAP or anything like that, or an NIV, is probably not compatible with the nasal tube because it will break the seal for the pressure. And then there's also concern about how tight that device might be against your face, pressing the tube. And I really appreciate that you brought that up because it wasn't something that I remembered to even consider, but it is definitely a concern. James had a question about about the tube. If the balloon is out. I just want to say that if you have a tube that's through your skin and the tube is out, that you need to get something in it within about 6 hours, or that hole might close up. I'm not sure what you're asking about a balloon. If the balloon breaks, and they do, if you can hold it in there, then it's, at least will prevent you from needing anything immediate as long as you can hold it in. But that makes it hard, and you should get attention right away.
This
Okay.
it's my question.
Sorry.
That was my question for my husband, James.
Mm-hmm.
Can you hear?
Yeah, we can hear you.
Are you able to hear me?
Yes.
Okay. So we've been in the hospital almost 24 hours with this balloon sticking out of the opening. He's had a JG tube put in October, and their radiology and intervention, I think, wants him to wait till tomorrow.
Yeah.
Is
it a long tube? If it's a JG and the that was
yes?
in the stomach has popped out, that's not the end of the world. As long as something is holding that opening open, then waiting until tomorrow is fine.
Okay. So the balloon is not going to expand it in an abnormal way.
It's out all the way, correct?
The balloon's halfway out, so it's a bigger opening than he typically has.
Yeah, I guess I would be concerned about it being stretching the skin.
That's what I thought you had said. Thank you.
Yeah, I asked them whether or not you shouldn't just empty the balloon so it's not pressing on the skin like that.
Yeah.
Yeah.
They don't want to do anything till tomorrow, but thank you very much.
With the needle, and anyway, go on.
Right. Thank you.
Good luck.
Yeah.
James, go over to Nina.
Okay, Nina, please, you can go ahead and ask your question.
So can we go back to where you talked about that not everybody is going to need the feeding tube, that some people don't? If ALS, if the muscles weaken, why doesn't everybody? Who are the people that don't need it?
Well, I don't know that I know how to describe a predictive way of saying you won't need it. I think that the majority of people do, unless the people with spinal ALS seem to have a lower requirement for it, and I think it just has to do with which nerves are affected, and which muscles are then affected by those nerves. And it's sort of the nature of the disease to have various impacts. So not everybody has everything that everybody else does. And I'm sorry that there isn't a good way to predict that.
Yeah, and if I can follow up with that, there are people that I've known. My friend Mariah, who lived for 37 years, did not have a feeding tube, right? So there are all these are outliers.
Yeah.
But the truth is, it is something to think about sooner rather than later. And it's pulmonary function and swallowing. They kind of go hand in hand. What goes first?
Yeah.
Right. And so it's just really important to, check with your providers already.
Yeah.
One other thing I would share, I always see a feeding tube, it's an insurance policy. If you lose the ability to swallow, what do you do? My good friend John Ember, who's been gone a long time, I was visiting John one day. John was considered the finest contemporary painter in America. He didn't want a feeding tube. Gordon, who I took care of back in 97, 98, did not want a feeding tube. He eventually lost the ability to swallow, and he passed away sometime later. But in John's case, didn't want one. I'm visiting him one day, and his speech was starting to become difficult. Swallowing was starting to become difficult. Um, and he was just really out of sorts. And I knew him really, really well, so I knew what was up. I looked at him. I said, "John, are you thinking about changing your mind, needing the feeding tube?" And he's, "Ron, I don't know what to do," as he's pulling his hair out. And I said, "May I ask you a question?" He said, "Of course." I said, "John, are you ready to go?" And he looked at me. I said, "Are you ready to die?" And he went, "No." You get the feeding tube, because if we lose the ability to swallow, there you go. The feeding tube allows you guys more choices to live life. So, I mean, that's the challenge, that's the choice, that's the mystery, that's where the inquiry. And vast majority of the people say yes to a feeding tube. But deep respect for those that say, I don't want to do it. But then it's about self-exploration around that as well. So, okay, James?
Just to tie into that, it's the problem is that if you wait too long to decide that you want a feeding tube, it may not be possible to do without being and ending up on a ventilator or some other thing.
That's true.
So it's better to decide early, and
And
and it's unfortunate because you never know what you're going to decide until you're in the situation, really. But in this situation, I think that it really is a good preventive tool.
no question. And how do you know until you know? And again, David was speaking of general anesthesia. Unfortunately, now they do something called twilight when there's concern about one's lung capacity. But again, these are conversations that are good to have along the way before it's in need. So,
So a
Hey,
couple of questions on the chat that I'd be happy to discuss. One is caregiver burden, and that's really always an issue. But for the feeding tubes, they're really easy to learn how to use, as are the intravenous nutrition. It may be scary at first, but it's not that hard to learn. Also, just in terms of the deciding about the feeding tube, a lot of people have an impression that once you have a feeding tube, you are a vegetable in a bed, and that's not at all true. Even not even a little. And if you have a feeding tube, it doesn't stop you from eating by mouth. The idea is to gradually, as your ability to eat lessens, then your dependence on the tube would increase, but it won't affect whether or not you're going to be able to eat or drink. And then somebody was asking about nausea with a feeding tube. Will the feeding tube help with that? It really, really depends. There's so many different reasons to have nausea, and there aren't that many of them that the feeding tube that tube feeding might address. It's pretty unusual that, but it's possible that your stomach is upset for not being fed, and it might help. But I wouldn't do it solely for that reason. Madeline asked about a couple of different products, and as I said, I really don't think that either of them. I mean, Liquid Hope has a really sexy name. That's its advantage over Nutrin, as far as I know. And Kathy asked about the breathing measurement range. I don't really know the answer to that. That's something that an anesthesiologist or somebody who specializes in the area might know. Dana, you had a question.
Yeah, hi. I don't have a question. I just wanted to give my family's experience. I'm a volunteer who works with CCLS now, but I was a caregiver for my husband who had ALS, and I think the point you brought up about autonomy is super important. He was happy to get a feeding tube, but he did not want a ventilator. He got his feeding tube about 6 months before he needed it. And so basically it was just hanging out, waiting for him to need it.
Right.
And we, would flush it every once in a while, but he was much stronger when he got it. And he had a little complication during the operation, and he was able to get through all that stuff perfectly well.
Right.
And he never aspirated, never had pneumonia. I think we were very, very lucky. And so I would certainly second what you and Ron said about It's
Yeah.
better to get it before you need it or get it and not need it, change your mind, than change your mind and not be able to get one. And it was perfectly easy for him to live with it. And as a caregiver, very easy for me to handle it. Used it for food and medicine. So I would highly recommend it. If you're thinking about it, and I'm more than willing to talk to anybody who is interested and wants to hear somebody who went through it.
Thanks, Dana.
Thanks.
Yeah.
Nina, did you have another thought?
It got answered. I was also wondering about the cardio respiratory, what's that limit? 50%, 45%,
Yeah.
but
I don't spend any time in the procedure room, so I really couldn't say. But I know that people who specialize in like perioperative risk assessment could probably give you numbers. But
So, and what I know about that, and I'm not sure if this is still true, but what I remember hearing over the years is insurance is kind of like a BiPAP machine, in non-invasive ventilation. They don't want to cover it until your vital lung capacity gets to around 50. And the same thing with feeding tubes, they want to cover it until, but, in my experience, good neurologists, good people in the medical world know how to make it happen, and sooner
yeah,
than later, often. So
yeah.
I just wanted to say something. My husband just got a feeding tube. This is Madeline. Is that okay if I talk for a
yeah,
second?
Madeline, hi. Yeah.
Okay, I don't know if you guys can hear me.
Yep.
Just whatever. We have Blue Cross insurance, and they covered 50% of the tube feeding stuff, just so you know. And then um, they give you these disposable, like an IV bag to put the food in every day, and they say you need to use one bag a day. And I don't. It's so much plastic. I don't like to throw it all out. I'm sure that by the book, I'm supposed to, but we rinse it out with hot water. I don't know if anyone else has any comments or experience with that. And then in other words, I'm not using one every single day. I just am not. And then the other thing is, I noticed my husband really stopped eating, which was fine with me. In terms of a caregiver, it's easier for me to give him 2 cans of food via the tube than it is to hand feed him, you know, a whole meal. But I did notice he kind of stopped eating, and I just was wondering, is that typical?
Well, if you're feeding him with the tube, you're going to say you're going to suppress the appetite. And I think it's up to the individual. If you want to be hungry, then you feed a little less with the feeding tube. I'll also say that there are other methods for feeding that are a whole lot less burdensome than using these bags. The concern with the bags is that you not get the bacterial overgrowth in the feeding product, which can cause diarrhea. But this is all, I think, my own opinion, a little overblown. But the national guidelines say only use one bag once, and that's it. But did they provide you with big syringes, 60 cc syringes?
Oh yeah, they give you one per week.
Okay, well, allow me to teach you a little something. If you take the syringe and you take the plunger out of it and you put it on the end of the tube, it becomes a funnel. And you just take the can and pour it in. You lift it up, it'll go faster. You lower it, it goes slower. And you just run it in that way. And it's just very simple. And it's more like a meal than waiting hours for that bag to empty. And you can do a can in 15 minutes, and then run water through that. That might be a simpler option for you and a little less wasteful.
So
And
you
I think
take the plunger out, so you just have the outside of it. And where do you put it?
you just hook it to the end of the tube. You plug it in. You got that syringe in order to flush out the tube, right?
Yes. Yep.
Yeah.
Oh,
Well,
I see. I see. You
yeah,
just
you
put it.
just take the plunger out and put it on top, and now you've got a funnel, and you can just pour it in, and the feeding will just run in with gravity. Don't put the plunger in, or you're going to end up making a
Okay.
mess.
But you
But
have to hold. But you have to hold it the whole time, right?
yeah, you have to hold it. It's
Yeah.
10 or 15
Yeah.
minutes to put a couple cans in. Really, it goes quite fast.
Yeah.
And
Yeah.
two things. In my experience, what I witness often is people eventually lose their appetite. And, is it because I've been living with ALS for 1 year, 2 years, 3 years, and my body's going through and my body's going through? I think it could be just a very natural unfolding. And likewise, if you, Madeline, if you want to reach out to the office, probably on Tuesday, we might have some, bags at our warehouse. I don't know, but if you reach out, we can check for you. Okay.
That's all right. I have them. I probably should just use them at least every other day. So I will do that
Okay.
because I should just use
Great.
them. But yeah, I thought it was kind of funny. They only covered 50% of it, but I know most people have Medicare, but we still have our Blue Cross. So I thought that was kind of weird, but I
Well,
guess
now
you're not buying
that's why
groceries.
so many people go to making it on their own.
Oh, okay. Sorry, I did miss.
But then, I mean, the advantage of using the commercial product is it's defined, you know exactly what you're getting and you know you're getting the right amount, or at least what we think is the right amount. So anyway, Dana pointed out that there's a holder called a buckwheat that they got to hold the tube. Just FYI.
And yeah, I mean, whoever put that comment, if you reach out to us, it's possible we might have one already.
And I really I meant to make a slide of this, and I really am sorry. Everybody write this down. This is really important. The Oley Foundation, Oley Foundation,
Olay.
Oley. It's pronounced Oley, and it is in upstate New York, a nonprofit that is devoted to supporting people who need artificial feeding outside the hospital. So anybody who's got a feeding tube, contact the Oley Foundation. Look at their website. They have all kinds of resources and people who you can ask questions about these very same things. And they're wonderful. And I'll say no more about that, but oley.org.
Yep.
There's one other question here from Wendy. She's asking if a feeding device requires a caregiver, how would you do it if you live alone?
It does not require a caregiver if you can manage it alone. The problem is if you lose the strength in order to manage it, that's a very different situation. And generally speaking, people who don't have a caregiver and who've lost that much strength are probably going to need some professional help at home or to be somewhere in a facility or some sort like that. Mm-hmm. But the feeding itself does not require anybody else to get involved. And in fact, where I learned this trick with pouring it into the empty syringe was in a population of patients with head and neck cancer. And patients were doing it themselves. It is dependent on your own abilities as to whether or not you need a caregiver for any part of any of this.
Exactly.
So
again, if you don't have hands, there's an issue there. And like David said, it's, where do we get that support? But David, chime in on this. There's different delivery systems for feeding tubes.
Yes.
Can you talk? I know there's bolus, there's gravity bags, and I personally like the timer clock if insurance would cover it. Can you talk about those, David?
What was the last thing?
There's one that's a clock. It's on a timer.
Oh, a timer. Yeah.
Yeah.
That's very convenient, especially if, one of the things that I think what you're talking about, Ron, is a system that you can set up and leave if you're the caregiver and the person can't manage by themselves, and then it turns on by itself. And that's very useful in that kind of situation where the caregiver can't be around all the time and the person can't themselves manage the tube feeding. That's good. There are lots of tube delivery means. There is the rate that you're talking about, and then there's the machinery. So let's first talk about the rate. There's continuous, and then what we call bolus. And a bolus is like you get it all at once, like a big, but not really all at once. You get it over a few 20 minutes or so. We sort of talked about bolus feeding using the syringe and so forth. That's useful because it takes less time. It goes much faster and you don't have to be hooked up to a tube for as long. The downside of that is that you have to have hands in order to do that. the physiology of this has been looked at, and it really, we can't tell whether or not one is better than the other in terms of, being fed in meals, which is really what bolus feeding is. Is that better? If somebody, sometimes people get hungry, and does that suppress their hunger better than continuous feeding? And the answer is we don't really know. The studies have not been consistent in their results. So it's going to be trial and error as to what's better for you, and how you're feeling in terms of continuous versus bolus. Continuous feeding can be short, or all day, all night, anywhere in between, or it can be in episodes, sort of like a bolus but slower, and can be done any number of different ways, including by gravity, which is the least reliable and oftentimes the slowest, because the pump, which is the next step, will speed things up and will actually push the thick feeding material stuff through the tube. And then, as Ron mentioned, there are timed pumps, which really provide a lot of relief around caregiver scheduling and so forth. So those are those are the high notes for that. What was I going to say? Yeah, some people prefer to be fed overnight on a pump. Some people like it during the day or in episodes. It really is up to you, and you can play with it as you see fit. But do so with the supervision of somebody who kind of knows something about this, a dietitian or the company that's providing you with the products and so forth. And again, if you're going to make up your own feed product, I think Oli is a good resource for recipes, but you got to be careful and make sure that you've got a balanced diet, just like you would if you were eating, because ice cream every day is not necessarily going to give you all your vitamins and minerals, even if it is good. I can't remember what else I was going to say, but that's, anybody else have anything?
I think we should wrap it up for now. And if you have another question, please feel free to email me, james@ccals.org, and I'll forward that to Ron or Dr. Seres. But thank you very much, everyone, for joining us. Thank you, David. Wonderful information. And Ron, of course, always good to have your voice in the mix. So have a great Sunday, everyone, and thanks for joining us.
Thank you, everybody.